Hello, and thank you for joining us for our second lecture for vascular ultrasound for the point of care provider. We're going to look at specific techniques in point of care ultrasound today so that you can utilize those and jump right into your scanning with some confidence that you're doing everything you can to identify any abnormalities that exist. So our objectives for today are to evaluate standard vascular approaches utilizing B mode in long and transverse orientation, using color Doppler and spectral Doppler. We're also going to talk about how to demonstrate appropriate use of Doppler gait and angle in arterial scanning to obtain the most accurate velocities possible. We're going to differentiate between monophasic, biphasic, and triphasic pulsatile waveforms and identify the conditions under which each of these are visualized, as well as evaluate physicity of venous flow and causes of this disruption of that physicity, explain the use of augment and Valsalva in venous ultrasound scans, and identify the most common venous and arterial pathology noted on a limited vascular focus exam. So we know that, you are all very busy providers and you may not have the time to sit down and do a full scan that would be done in an imaging department. So when we're going to be focusing on these ultrasound techniques, what we really want to do is teach you the basics of good standard practices. And then when we get into the individual exams in the following lectures, we'll talk more about exactly the locations of where you're going to want to implement these practices in order to get the most bang for your time. So first of all, we're going to start by talking about scanning the vascular system. So as providers, you all are familiar with this, but as a quick reminder, we know that the arterial and venous system both have the same layers. They have the tunica intima internally here. They have the tunica media, which is the muscular layer here, and the tunica adventitia. So the biggest difference between our artery and our vein is not the types of layers or the types of tissue. It's going to really be the thickness of that tunica media. Because that tunica media is so much thicker and stronger, it's going to maintain a more circular shape and be less compressible than its venous counterpart. So you can see here, venous is very easily compressed, artery is not. That's going to be really important when we're scanning because lots of times we're going to want to compress the vein to make sure that there's no thrombus in there. If there's no thrombus, it should compress completely wall to wall. If there is thrombus, even if we can't visualize the thrombus, we'll get that inability to compress it. If we press so hard trying to compress that thrombus that we don't see, then we'll start to distort the artery. And at that point, when we start to distort that artery, we know that we're pressing too hard. So it's a fine line between getting compression of the vein without affecting the corresponding artery. When we're scanning our arterial and venous system, we're utilizing our high-frequency linear transducer for most of our superficial scanning. So if you're going to be doing a carotid, lower extremity DVT study, and upper extremity DVT study, those are all things that would probably utilize something like a 9 to 12 linear transducer. If we have something maybe more abdominal, you want to look at the aorta, then you're going to switch to your curvilinear or sector. Now, some patients, depending on habitus, may have very thick legs or something like that. And in that case, never be afraid to stray away from that high frequency transducer and go to a lower frequency transducer just to get the penetration you need. Remember that high frequency is going to give you the best resolution, but at the loss of penetration. So don't be afraid to change those out. If you're struggling with one, go ahead and switch to another. When we look at the arterial system specifically, we know that when we're going to utilize our spectral scanning, taking those waveforms, we're going to see a pulsatile Doppler. Because of that tunica media being thicker, it's going to be more difficult to compress that artery. And then we should see that there's some compliance in that artery when there's not significant atherosclerosis present. Now, we do see a change in waveforms when we have significant atherosclerosis or just overall hardening or loss of compliance of the artery. So that's really going to affect your what would be a normal waveform for that patient. The venous system demonstrates phasic flow in the phases of respiration rather than that pulsatile flow from in the arterial system. It can be very easy to accidentally, especially when you're in long axis on an artery or vein, to slide from an artery into a vein. So identifying those changes of pulsatility or phasicity can really help you, reorient yourself to where you're at. And like we said, venous veins are going to be very compressible in the absence of thrombus, and in the presence of thrombus, that can really limit their compressibility. So we're going to start out by talking about arterial scanning in B mode. And so with arterial scanning, as well as venous scanning, we're going to evaluate the vessel in long and transverse in B mode. B stands for brightness, and you can also think of it as black and white. So here's an example of a patient's carotid being scanned in long. You see how the long axis of the transducer is in alignment with the long axis of their carotid, and you're going to get an image like this. It does take some practice if you haven't used a lot of ultrasound to stay on that vessel. It's really easy for your hand to wander. This operator here might have some improvement in wandering hand by lowering their hand on the transducer and actually resting it on the patient's skin. To get 90 degrees to this long axis of the carotid artery, you can rotate your hand 90 degrees and get a transverse view. So now we see that carotid on end rather than in length. It's a little bit easier to stay on that carotid or on any vessel in transverse. If you have the time and the ability, you want to scan through the entire vessel in both planes. Obviously, the carotid's a short vessel. It's pretty easy to do that efficiently. When you get to the longer vessels of the leg and arm, that can be a little bit more challenging, so we'll kind of teach you the spots that you want to pay special attention to. In a general imaging suite, we would go through the vessels all the way through the entirety of the vessels to the best of our ability. When we're looking at the arterial vessels, we're going to look for wall continuity, watching that tunica intima when possible, looking for the continuous flow of those walls, because that flow is going to be, will optimize that smooth flow of blood within the vessel. When you have things like nicotine use or diabetes or other sort of hypertension, other sort of vascular diseases, that's when you're going to start seeing the initial forms of plaque buildup, which actually start out usually at a bifurcation, and it's usually due to those to roughening up of the wall. So by paying close attention to this tunica intima, you can really assess for any early changes in that vessel. Again, because of that lack of wall continuity, you may start to see intimal thickening, and that would be, the first stages of plaque buildup. You're also going to want to look for aneurysmal changes, which we'll talk about. These can be true or they can be pseudo or false. Usually those pseudoaneurysmal appearance will be after some sort of trauma or iatrogenic accident effect. We can also see arteriosclerosis, or that buildup of plaque, and then on some occasion, not as often as in the venous system, but we will be able to find thrombus in the arterial system. So once we've scanned the full vessel, the full arterial vessel that we're looking at in B mode, in long and transverse, then we would want to add our color flow. So with color, you're going to want to evaluate specifically in long. Transverse is not as useful, but it can be helpful, so keep that in your pocket. With this, again, if you have the time, you're going to want to scan through the entire vessel, and you want to optimize your settings. So this can be some of the most frustrating parts for somebody that's really familiar with the anatomy and the physiology, and yet you're having trouble getting your machine to demonstrate what you know exists there. So some of the things that are going to be most useful for you is to utilize your color gain. The best practices in vascular scanning with color gain is basically turning up or down your color, making it more or less prominent. So one of the best practices is to do something like you see here in A. So in this case, they would be scanning through the carotid artery. They turn the color way up as high as they can, and then you start to taper off, turning that color down, 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 until you feel like you've gotten rid of all the artifact, which is in B. So that's how you are able to demonstrate the most sensitive color there is. If you leave it too high, you're going to get artifact. If you turn it too low, you're going to be missing where blood flow actually exists. So getting it just right here to the sweet spot is going to be very important. So make sure you find your color gain button and are willing and ready to adjust that. The second thing that you want to be able to adjust, and we can use this as an example too, would be the scale. So the scale looks something like this. It'll appear on your screen. And you can say this scale is set with the baseline here at 0, with forward motion 73 centimeters per second, or reverse motion 73 centimeters per second. If my blood flow happened to be going faster than 73 centimeters per second, what we would see is called aliasing or wraparound. So anything over 73 would start showing up on the other side of this spectrum as blue. So in this case, they probably have their scale set too low, their gain is too high, but we're seeing this wraparound where I know that I don't have blood moving forward and backward in this region. It's aliasing from an inaccurate scale. So by increasing my scale until everything that's going forward turns red, I know that I'm getting an accurate image. And then lastly, wall filter. So color is going to be demonstrated anywhere that the ultrasound is indicating that there's movement. So we know that the compliance of that artery, it's going to be taking on potential energy as it expands with the volume of blood within it. And as it does that, it's going to move. And then during diastole, as that blood volume decreases a little bit, it is going to kind of contract. And so because of that pulsatility of movement of expansion and contraction, due to its compliance, we're going to see some movement here, which you can recognize in the blue here. Now, we don't really want that to distract us. We want to be able to see the tunica intima here. And so in order to get rid of what we know is wall, we have something called the wall filter. So if you are seeing artifact in your wall, you can increase your wall filter until that disappears. Now, if you increase it too much, you're going to decrease your ability to visualize what's in the periphery of your vessel. So again, you're looking for that one sweet spot where you can see everything you want to see. Now, there are some pathologic indicators where we can watch this color, and you might even see some mixture of color that actually isn't aliasing. We often see that in areas of very increased velocity, like in the center of a stenosis, areas of disturbed flow, areas of turbulence after a stenosis, or we can see if we can't pick up color, it might be because there truly is a lack of flow there. Even a vessel that we see, we know it should have color in it, but perhaps there's some sort of stenosis that we're unable to identify. We're getting a lack of flow. So in this case, it wouldn't be our settings. It would be a real pathologic indicator. And then sometimes we can see reversal of flow. So again, kind of like that turbulence where we know flow should be going one direction and yet we're seeing it come the other direction. That would indicate that that's a pathologic condition. This happens a lot in like the vertebral artery when you have a subclavian steal where you're tempted, because we have the ability to actually flip this scale to say, I want blue moving toward the transducer and red moving away. And we can be tempted to do that to make a vessel look red or blue, but it's something that you really want to take some time and think about, because that inaccurate color in your perception could actually be indicating that there is some sort of pathology. Now, how you know which way you want to angle your color or what you want on top versus bottom is going to depend on how you've positioned your color box. So in here, you can kind of vaguely see this parallelogram, and that indicates that the color box is angled this direction. So if the blood is flowing towards those scan lines as it is in this as it is in this direction, they're going to crash into each other and indicate a Doppler shift, a positive Doppler shift like we talked about last week, which will be indicated in forward flow. Since red is above the line, in this case, this is all showing that blood is flowing cephalically in this carotid artery, or from the heart to the brain. Okay, now I can make a change and I could actually flip my color box to go this direction. And if that were the case, I would have blue flow because it would be going away, traveling away from those scan lines. And that blue flow could be confusing because I would think that often we think blue is away from the head. So in that case, I would need to check my color box. I need to check what I have on my scale over here, and I need to take the time to critically think it through. Which direction is this blood moving? Is it accurate? Is it something I have an error in, or is it something pathologic? So here's just some examples of what we're talking about when we're talking about what the areas we're going to look at. So here you can see this is the tunica intima. This is an older image, but you can see that there's this disruption in the continuity of the tunica intima. You can see that it actually has a line of tunica intima here with a thickening behind it, probably indicating some fibrotic plaque. Here would be an earlier stage of a pathologic change where you just kind of see a little bit of roughening of that tunica intima. And obviously, once that becomes roughened, things are more likely to kind of stick or adhere to it. And so that's going to be the beginning development of plaques. Now here you see something where this is probably the external carotid. And so at the bulb here, we're seeing some flow. The lack of flow here could either be a scale problem, so we'd want to decrease our scale, making it more and more sensitive. We'd want to increase our color gain. And if we still couldn't get any flow here, that would indicate that there is possible occlusion. But you want to pull out on all the stops with your scale, your gain, all of that to make sure that there truly isn't any flow there, because that difference between a minimal amount of flow and no flow at all means that patient's a surgical candidate versus is not. Here you see how that disruption of the intimal wall appears a little bit differently. It's a little bit hypoechoic this time, and yet you can certainly see the disruption of the flow. So where this might have been something overlooked on B mode imaging, having that color and watching the contour of the color can be very useful. This is showing color. It's showing a B mode image in the center here. You're not getting any color flow through that B mode. So in that case, you'd want to increase your color gain. You'd want to decrease your color scale. You might even want to change to power Doppler to ensure that there is something there. This is really not echogenic like a lot of plaques might be. So this could be indicative of maybe a thrombus that are going to be a little bit more subtle. Okay, and then here again, you see some irregularity in that wall. You see this disruption in the intima here. Here, you're going to identify that aliasing from turbulence. So it's showing that blood is moving away here and toward here. And so it's moving kind of in like a dishwasher sort of effect or a washing machine kind of effect, causing turbulence, indicating that there is something in this region preventing the blood from flowing normally. Now, when we add spectral scanning to our Dopplers, we are going to have to concentrate on a number of different things. So spectral is obtained in long. You don't have to worry about obtaining spectral in transverse. The important things to remember is that you want to take this little gate, this little kind of cursor thing here, or equal sign, and you want to set that at the center of your vessel. You also have an ability to control your gate size. So you can open it up really wide, you can narrow it down really small. What we really want is typically something pretty moderate to pick up the flow right in the center of the vessel, not so large that it's going to be picking up that peripheral flow, not so small that it's not getting a large enough sample. The second thing that you want to do is look at this line here. This is your Doppler angle. Now on your equipment, it's going to give you a readout. It will tell you in degrees what your Doppler angle is. Now, we talked about last week how we like a Doppler angle of 0, we like a Doppler angle of 30 to 60. So we have to make sure that this Doppler angle is not only parallel with my vessel wall, but that it really falls typically between between 30 and 60 degrees. Occasionally you can use a 0-degree angle. It works well like on the portal vein or something that you can get perpendicular access to. But most of the time you're going to be working in that 30 to 60 degree range. Now the importance of this again is it's to get accurate velocities. We looked at how last week we have to calculate velocities by utilizing a cosine of the angle we're obtaining the velocities at. And so by making sure that we have the correct angle and that angle is parallel to the vessel will really allow us to be accurate in our velocities. That being said, when we go to the venous samples, we're not really looking at velocities, we're looking at waveforms. You can actually leave your Doppler angle out of that. Also, if you're doing something that's a ratio, like a systolic to diastolic ratio, you don't need to watch your angle for ratios. It's really because the Doppler angle will affect the systole at the same rate as it'll affect the diastole, and so you still get an accurate ratio without watching that. So it's really for those velocity measurements that you're going to make sure you're following these protocols very carefully. So at your 30, so again, vessel is here. I'm making my gate centered, open just enough to get a good sample. I've got a parallel gate. And I'm going to double check and make sure that my Doppler line is between 30 and 60. That is going to optimize my accuracy. Now, sometimes you'll find this challenging in that when you get your angle at 30 to 60, it can't be parallel with your vessel wall. And in that case, your only option is to actually change the angle of your hand. So maybe move your hand up and scan back. to change the angle of that vessel across your screen. So be aware that that can be a challenge. And so, when you're working, with the hands-on part, if you need support in being able to accomplish that, that's a great time to do it. If not, with a lot of practice, it becomes eventually natural. When we're looking at our spectral outcome, here's some examples of spectral outcome. We are also going to be wanting to consider adjusting the scale, the gain, and the baseline. I'm going to start with gain first, because if you're taking a sample and you can't hardly see it because it's so black on your screen, that's when you're going to increase the gain. So that gain is just going to increase the brightness and the sensitivity of what it shows on your spectral analysis. The scale, on the other hand, this is an example of where the scale is set from 0 to, let's say, 40 centimeters per second. Let's say the blood is moving at 80 centimeters per second. There's nowhere to draw that on our scale. And so again, kind of like it did with color, it's going to wrap around an alias underneath the line. So a couple things that you could do here is you could either increase the scale to just bring it up higher, or you could decrease, since we don't have anything in reverse of baseline, you could actually move the baseline down until you don't see any more of that aliasing. So scale, gain, baseline, those are all going to be very important buttons that you want to become familiar with. Now, if you happen to find a stenosis, we talked about last week how the velocity is going to peak in the center of a stenosis. So let's say that there was a stenosis right in this region. I would take my gate and I would slowly walk it through that stenosis, looking for any spikes or peaks of velocities, and that's where I would take my measurements at the stenosis. Now, we have a number of different arterial spectral waveforms. We talked about them briefly last week, but I thought it might be worthwhile to go a little bit more in depth in this. So first of all, we know arterial blood flow is controlled basically by our heart, which is going to go through pulsatility changes during systole and diastole. So all of our arterial flow should be pulsatile. If we have very low resistance arterial flow, we'll have something that looks like this called biphasic, or some people refer to it as monophasic. That can be a little bit challenging because it's very different from the monophasic that we're going to talk about shortly. So this is an example of very low resistance biphasic flow where we get good systolic upstroke during the heart contraction. Blood moves forward quickly, and then during diastole, it just easily flows forward through all of diastole. It never gets close to this 0 point. So that is going to indicate that I have a very low resistance to this blood flow moving forward. Low resistance would probably mean that I have a low resistance tissue bed that needs a lot of blood flow. I also have nice open arterioles, which is letting that blood flow in, and that I also probably have relatively open arteries that is not obstructing the flow that is required to those tissues. So this is a nice low resistance flow. You see this is an open window below, meaning that they probably had good gate positioning in the center of the vessel. If they had opened that gate too wide, they would detect slower blood flow at the periphery of the vessel, and you would see this window area fill in. So lots of good things going on here. This is the type of flow that you might expect to see in the splanchnic vessels of the abdomen. So in your superior mesenteric, superior mesenteric artery can be complicated because it depends on your prandial state. But let's say the spleen, let's say the liver, this is classic for an ovary, a testicle, anything that's going to have very low resistance flow. Now, if I have something that has a little bit more resistance, you see that I can still have this biphasic flow, monophasic flow. It's all above the baseline. Good systolic upstroke means when that heart pushes, that blood's readily able to move forward. But you see the peak is much higher, and it almost reaches the baseline before that Windkessel or that hydrostatic pump effect kicks in. So in this case, this would go forward, almost come to a stop, but then have low enough resistance to flow forward all the way through diastole. So this again is biphasic, relatively low resistance flow, and yet it certainly is higher resistant and different than we see here in our very low resistance flow. So this could indicate a little bit of stenosis up ahead if it was feeding a very low resistance tissue bed, or it could mean that it's feeding a tissue bed that has a little bit higher resistance, maybe a muscle at rest or something like that. Now, as we go to higher resistance, you'll see that this is now our triphasic flow. So we're getting good systolic peak, and then as we enter diastole, that blood flows to a stop, and the resistance ahead actually pushes the blood backwards until that Windkessel or that potential difference effect kicks in, and that arterial system compresses, pushing that blood flow forward again, and then systole kicks in again. Now, this could indicate that we have a nice high resistant bed, tissue bed, which could be something like, the calf muscles at rest, or something else that demonstrates high resistance. Or this could mean that I actually have a low resistance bed with a big stenosis that's creating resistance between my sample size and the tissue bed. So we have to know what's normal for each vessel that we're looking at. Now, this monophasic is extremely high resistance. This usually means this patient is in arterial trouble. So what's happening here is that we're getting systolic flow forward. As soon as systole ends, it crashes to a stop. Because the arterial system is congested, we don't get any reversal of flow, we don't get any forward flow. This is just called monophasic, so we have just, it's almost, I think of it like banging your head against the wall. The heart beats, you hit your head, you stop, you hit your head again. So there's just no forward motion to go. So this would be something we would see pre-stenosis as we're coming into a stenotic bed. Okay, so here's a little bit more description, just like some of the things that we're going to see. So that biphasic means we have low resistance bed ahead. It means that we get that low resistance from high tissue metabolic needs, which result in dilated arterioles. The presence and velocity of the flow during diastole describes just how low the resistance in the tissue bed is. So we know that biphasic flow here looks very different from biphasic flow here. They're both lower resistance, but obviously this one is much lower resistance than this one. The other thing that biphasic flow can mean is that we are actually post-stenosis. So if I have maybe a higher resistance artery, and then I have a big stenosis, despite the law of continuity, at a certain point, the flow in my stenotic area cannot keep up to the flow that was pre-stenosis. So the amount of blood that gets through here is going to be lower than the amount of blood here, leading to a low pressure state post-stenosis. If that is the case, my tissues won't be getting as much blood as they need, and therefore they will undergo arterial dilatation, which could result in a lower than expected resistance waveform. Our triphasic flow we see here, this is going to be expected in our high resistant tissue beds if we're feeding a high resistance tissue bed ahead, or if we have arterial constriction for some reason, maybe a patient has Raynaud's phenomenon or something where their vessels are constricting, then you'll see these more higher resistant waveforms. That would be the normal. However, these can be abnormal when they're feeding a low resistance tissue bed. If we see this, it's going to be concerning because that would indicate that there's something is causing resistance ahead, and most often that's going to be a stenosis. Monophasic, like I said, this is an indicator that we have poor blood flow. It is high resistance ahead, and it's unable to maintain volume through the stenotic area, and so we have significant resistance and a backing up of blood upstream. Okay, so now let's say that we did find a stenosis, so it could look something like this. What do we expect to see? So before the stenosis, we can see an increased resistance in what we would expect in that area. So let's say that I have, this is a femoral artery, and femoral arteries are going to, at rest, have maybe a triphasic flow. After activity, you might even have a biphasic flow. So here are our waveform at rest. We're seeing that we have this biphasic flow, but we don't have any forward motion in diastole, which would be very uncommon. So that's telling me that there's something causing resistance or pressure up ahead, preventing that forward flow in late diastole. So because of that, I know that there is something upstream. So as I move upstream, I'm going to find that I'm going to have a more normalized flow, where you can see here where I get this more normal low resistance flow. But if I check the velocities of that flow, they're going to be very, very, very fast. So here's an example of what you might see here with these high peaks of velocity going about 400 centimeters per second. So we know that we get an increase in velocity at stenosis, and so by walking that gate through that stenosis, we can find the highest peak of velocity. So we have coming into the stenosis, we have higher resistance. At the stenosis, we're going to have a drop in resistance, but an increase in velocity. Post-stenosis, we're going to get some turbulence. So you'll see some spectral broadening. You might see some reversal of flow, all of that here in the turbulent area. And then as you go farther and farther from the stenosis, you're going to end up with a lower than expected resistant flow. Okay, so some of the most common arterial pathologies, certainly this is not all inclusive, but these are the things that you're most likely to be looking at in your point of care practices. So aneurysms, we have three different types. We have the fusiform, the saccular, and the pseudo. So the fusiform, if I have, let's say, an aorta and I have a fusiform aneurysm, it's going to look something like this, where it's dilated in an entire diameter. Okay, so this would be an example here of a fusiform. Right here, it's dilated on both sides. Anything in the aorta over 3 centimeters is typically considered an aneurysm. Other vessels, of course, are going to have different measurements that would determine whether it's classified as aneurysm or not. So that's going to be your fusiform. Your saccular aneurysms are going to be oftentimes just a weakening of one wall, so they'll pouch out like a sac. These are going to be high risk for having stasis within that saccular component and creating a blood clot. And then finally, you have a pseudoaneurysm that's not really an aneurysm at all. It would be often after trauma or an iatrogenic injury, where there's going to be a little bit of leak and a blood clot forms outside of the vessel. So this is more of actually a clot than an aneurysm, and so we call that a pseudoclot or pseudoaneurysm. Now, if we do have a true aneurysm, obviously they're at higher risk for rupture. They're also at higher risk for thrombus. And the reason why this is because of how blood flow works. It's going to come in here from a narrow vessel into a huge vessel, and the blood is going to start becoming turbulent. As the blood starts to become turbulent in here, it's not going to just flow through and move on. Turbulence means stasis. Stasis gives the blood time to start clotting. And so you can see here that aneurysm puts you at high risk for thrombus in the aneurysmal area. So in this particular case, you can see the color is still moving, or the flow is still moving in generally a normal size lumen. But if we make sure our grayscale is adequate, you can see that we have thrombus taking up most of that aneurysm. That's the important thing when you're scanning your vascular, is that you want to always optimize your settings so you wouldn't make it too dark or so bright that you would hide this. You always want to make sure that you have optimal black and white gain settings and optimal color settings. So obviously some of the main things you're going to see or be looking for on your point of care vascular scanning would be plaques in the arterial system. So we have different types of plaques. Probably the most obvious and easiest to identify is going to be your calcified plaque, which you see here. These will be echogenic or bright, and they're going to have some posterior shadowing off of them. They can be smooth, they can be rough, they can be a number of different appearances. These are most often going to start at the bifurcation, where the walls of those vessels are going to experience the most disturbed flow, and so that's where you're going to see those originally. So here you see at the carotid bulb, you're seeing the internal and external, both are getting a little bit of plaque in there. Now it takes a pretty significant plaque obstruction or not obstruction, but stenosis to cause actual hemodynamic or blood flow changes. So you often won't even see a change in velocities until they're almost 75% stenosed. We can also have a mixed or variable plaque. This would be where there's some calcification, there's some fibrosis changes. They used to often call these ulcerated plaques. Now they just call them mixed appearance. And so they can have some shadowing, some smooth echogenicity, some even hypoechoic areas. And then we have the fibrotic plaques, which are hardest to see, so you want to make sure that you're optimizing your B mode gain and looking for those disruptions of any tunica intima. And so in this case, they're more like a scar tissue type change that will still cause a narrowing or a stenosis of the vessel. So all of these are going to have effects on Doppler. If they're somewhat smooth, they're not taking up over 75% of the vessel, then you're usually just going to see that disturbed flow where all of your flow will still maintain parallel lines and just reroute themselves around the plaque. Once it gets to a more significant extent, that's where you're going to see those increases in velocities, the upstream increase in resistance, the in stenosis increase in velocities, the post-stenotic turbulence, and then the low resistance post-stenosis. All of these will really start as early stages as intimal thickening. And again, it's all those atherosclerotic disease factors that put you at higher risk for that. So the smoking, the diabetes, the high blood pressure, all of that. Thrombus, like I said, this is going to be less common in the arterial system than in the venous system that we recognize this. And we can use Virchow's triad to predict how likely a patient is to be affected by thrombus. So usually somebody that's affected by thrombus is going to meet one or more criteria of Virchow's triad. So Virchow's triad states that a person that is in a hypercoagulable state, either due to genetics or some other circumstance, cancer, something like that, will be more likely to get a clot. Those that have stasis, either from immobility or maybe from sitting for long periods of time, or from something like this example of this aneurysm where blood is getting into the aneurysm, becoming turbulent, not getting out, that would also cause an increased probability of thrombus. Other things that would be could cause that would be like a large abdominal mass that's compressing the flow, causing more static blood. That could also have an effect. Stasis is also much more common post-surgery where that patient isn't up and moving. And then that leads into injury and trauma. So patient that's undergone a trauma, injury, or surgery would have a higher probability of creating a clot. So as I said, they're not as common in the arterial system as the venous system because clots appearance change over time, as we're going to talk about when we get to the venous system. The appearance of these may be variable. So they're going to start out as very low-level echoes. They'll become more organized and become a little bit more echogenic. Over time, they become more and more echogenic, and then they begin to sort of break back down where you can see a mixed echogenicity. If they're able to completely resolve themselves, then they'll go back to a hypoechoic state. If they're unable to, they may stay in that mixed state or become very echogenic and almost calcified for a true chronic thrombus that's not going to go anywhere. Obviously, the thrombus in the arterial system is going to displace normal flow. So if you can't understand why your flow is displaced, always go back to your B mode, adjust your gain settings, and see if you can identify that there's some thrombus in there causing that. Another big concern in our arterial system would be dissection. We're not the best with ultrasound at looking at the thoracic vessels unless you're doing a full echo exam, and even that has some limitations. Most of our dissections are going to occur, off of the aortic arch, but they can occur anywhere in the body. So a dissection would be the tearing of that tunica intima from the medial wall, and it's going to create a true and false lumen. So the true lumen would be the lumen that is the original lumen that's still moving blood flow through. The false lumen would be the lumen that is basically a blunt end. So in this case that you can see the true lumen here is demonstrating the blue color. The false lumen is in this red color. As that false lumen keeps getting pounded with arterial pulsatile blood, it can continue to tear and tear and tear that intima away from the wall, causing that dissection to expand. With this, it can be a little bit challenging to identify because that tunica intima is so thin. Again, you're going to have to really watch your gain settings. These can also be confused with a thrombus. And so you want to make sure that you are demonstrating the true and false lumen in this case to help make that differential diagnosis. Now we're going to switch gears a little bit and talk about scanning the venous system. So like with arterial system, we're going to scan in B or brightness mode. We're going to look at color, and we're going to look at spectral Doppler. So again, similar to the arterial system, we're going to evaluate in long and transverse. The difference here being in that in transverse, we're going to be compressing the vessels. We can only do compressions in transverse because it's very highly likely that if you tried to do it in long, you'd be rolling off the vein and you wouldn't know if you were actually compressing it or not. The venous size can be more variable in size compared to the arteries. The arteries, because of that strong tunica media, are going to be very stable in their size and shape, whereas the veins are going to be very variable dependent on the pressure state of the vein at that particular moment you're looking at. So with full compression, we can make them disappear completely. If we create a high pressure state, say in the lower extremity venous system from a Valsalva, we can really dilate them. And then other things like, heart diseases or other things can also affect the state of the veins. It is really common for two veins to accompany one artery. In most of our extremity systems, we'll find that. We know that rather than following a pulsatile flow pattern, our veins are going to follow the phasic flow pattern with our breathing. So as we talked about last week, our veins don't have a pump. They're operating simply off of potential difference or differences in pressure. So our right atria is considered the 0 point or the low pressure point as long as we don't have heart disease. And so the farther a vein is from the heart and the more effect it has from hydrostatic pressure caused by gravity, the more dilated it's often going to become, and the more force it's going to need to move that blood flow forward. Anything that's going to increase the pressure between a vein and the heart is also going to cause that vein to become more dilated. So we can also, because of the flexibility of the vein wall itself, we can also manipulate that blood flow movement through other approaches. Our venous system also has valves, which we're going to look at. And then the nice thing about the venous system when you're doing the spectral Doppler is that you don't actually have to worry about Doppler angle. So when we're scanning the venous system in B mode, like I said, you're going to be looking in long and trying to make sure that your gain is set appropriately so that you could identify any low-level echoes that might indicate a thrombus. But we're really going to help identify those thrombi when we are looking in transverse with compression. So when we have an area we're looking for thrombus in, we are going to move the probe every couple centimeters and compress. The vein should compress, the artery should stay open. If we start to distort the artery in trying to get that venous compression, it probably means we're pushing too hard and that vein is not compressing for a reason. So in this example on the right, you can see here artery and vein. When with compression, that vein completely disappears, indicating that there would be no thrombus in that particular area of the vein. Again, this should be completed every 1 to 2 centimeters as you progress down a vein to determine if there is any thrombus or areas of concern. You must compress it all the way. The early acute thrombi can be very hypoechoic, and so even if you get most collapse of the vein, but not complete collapse, it could indicate that there is a thrombus there, and you'd want to evaluate that more carefully with color, looking for any disruption of the flow against that venous wall. And again, I can't emphasize enough that your B mode gain or your brightness mode gain is going to be very essential in making sure that there is no thrombus there. Just like we talked about with the color, with the B mode, you want to turn the color, or pardon me, you want to turn the gain up as high as possible so it's really overly bright, and then taper off on that until you feel like anything artifactual is gone. One thing that can occur in veins is something called reverberation artifact, where you'll see lines kind of in U-shaped lines coming down the vessel. That can be a little bit tricky in differentiating whether that is artifactual or if it's real. But if you turn on long on it, or even in transverse and add color, if it fills in with color, then you would know then it was just an artifact. Okay, so your second step after you have evaluated the vein in long and then in transverse and transverse with compressions, then you can actually add color. So because of the low flow state of the venous systems, especially in some areas, sometimes it can be really difficult to get color without some additional help. So again, you're going to do those standard practices of turning your color gain all the way up, tapering off on it until you see just what appears to be real color. Sometimes with that really low flow, if you're not detecting color, you can do something called augmenting, where you're actually going to squeeze the vein and try and produce color flow in that area. So a common area we use this is in the calf. Maybe I was looking for color in the popliteal and I wasn't seeing a lot of flow. By squeezing that vein, I would be forcing blood upward, and I would cause that appearance of flow only if there was no thrombus there. We also, when we have color, we want to look for those disruptions in the lumen. So if I was missing color in this particular area of the lumen, that would indicate that that's maybe somewhere I want to spend a little bit more time with my compressions and evaluate if there's a difficult thrombus to see in that region. Now, one of the most complex parts of evaluating the venous system is utilizing your spectral Doppler efficiently. So we know that phasic flow is going to be visualized in the venous system, but the appearance of that phasic flow is going to be different based off of the distance of the area you're evaluating from the heart. So in this case, we're looking at the right common femoral vein, and you see that this nice slow respiratory pattern. You're seeing blood moving forward during expiration, when the expiration is going to reduce abdominal pressure and then allow the flow from the legs to go into the abdomen. So you're seeing that nice flow during expiration. During inspiration, the thoracic pressure increases, during inspiration, that thoracic pressure would increase, increasing the abdominal pressure, and then we are going to have that reduction of flow until we take our next breath. So that would be normal phasicity distal from the heart. Now, if we're can look at this other example, it looks very different, and yet it's still flow, or it's still normal. So in this case, we have a higher respiration rate, and you're seeing that phasicity more frequently, yet still normal. As we get towards the heart, so this can occur like in the hepatic veins right before they dump into the IVC, or in this case in the subclavian vein. Sometimes you can see a little bit of reflection of the pulsatility from the right atria in that venous flow because of their close proximity. So a sample like this would not be abnormal in a vein that's proximal to or close to the heart. Other things that can affect the phasicity, besides just their location in proximity to the heart, would be dilatation of proximal veins. So if you have a congested system, either from cardiac failure, or maybe you have significant liver cirrhosis, all of that can cause dilatation of the veins, which would increase the pressure system in any vein distal to that. And so because of that, you will see changes in the phasicity or reduction in the phasicity because of that congestion. Varicose veins can also, usually that is caused by some sort of dilatation of the veins and an increase in the pressure system, so you may see less phasicity in those. Reflection of pulsatility, like I mentioned, in the venous system is normal proximal to the heart, or it can be normal if that heart's really struggling to move blood flow through. It's going to reverberate that pulsatility in the veins trying to get to the heart. So you might see more pulsatility in those systems as the heart struggles to retain basically a zero pressure point. We can also use different maneuvers in order to cause the blood to do things to test it. So one of the typical maneuvers we use is an augment, like I talked about for the color flow, just as it forced that flow forward, creating movement, creating a color a burst, we can use that to create a spectral burst as well. So here's an example where they were watching normal phasicity, and then this looks like probably a superficial femoral vein. And by grasping that calf, compressing the veins, it would have shoved a lot of blood flow forward. And you can see that in this big spectral whoosh pattern. And then as you let go, it goes back to its normal phasic pattern. If we have an augment that's unsuccessful, usually I'd try it again because I might have just not, collapsed or compressed the correct vein. But if I still can't see that augment movement and I'm still getting just a phasic movement even when I'm augmenting, that would mean that there is something between where I'm scanning. So if this is my vein, this is my transducer, and let's say this is where I'm going to augment. If that augment is not pushing that blood flow forward to create this pattern that I see here, it probably means that there is something obstructing it. So I would not detect that augment. So when we see a depressed or an unidentifiable augment, it would indicate that there is some sort of occlusion or obstruction between the site of augment and the site of scan. Another maneuver that we use frequently is the Valsalva maneuver. So this is where you're going to have your patient increase their abdominal pressure. So because the lower extremity veins are leading into the IVC, when we increase that abdominal pressure, it is basically going to collapse those veins and prevent movement through it. So in this particular case, you can see a pretty normal phasicity respiratory pattern. The patient valsalvas, increases that abdominal pressure. It cuts off the blood flow in forward motion until we let them release that valsalva, and then we see a whoosh or a movement forward of that blood flow again. So that would be a negative valsalva. So no blood flow during the valsalva maneuver. Now, another thing that can happen if we had a high pressure system and we valsalvaed, we would have the respiratory pattern coming into this, then they valsalva, and you see a reversal of blood flow. That would indicate that we have congestion in this venous system. When we shut off the forward motion of that blood supply, we actually had a reversal of flow down the legs. So this would indicate a reflux event during valsalva. Now, with valsalva, it is going to affect the body part depending on where we're looking at. If we were to look at the IVC during valsalva, let's say towards the liver region, and I increase that abdominal pressure is not going to cause the blood in the IVC to back up. It's actually going to force it out because the pressure is going to be compressing that vein. So we have to be really cognizant of our pressure systems and setting our expectations as to what that vein should be doing based off of the drainage pattern of that particular vein. Another thing that we can do is called the sniff test. This is something we use more often in the IVC and then in the upper extremities. So if you sniff, you have a really quick reduction in thoracic pressure. So if I reduce thoracic pressure and I am counting on my venous arm flow to go into my thorax, by reducing that thoracic pressure, I can actually cause almost an augmentation of that venous flow through the arm. Okay. Now, it doesn't work with respiration because respiration is going to be a slow change in that pressure, but the sniff has such a quick reduction in thoracic pressure that it will augment your arm veins. Now, on the other hand, with your IVC, a sniff is going to reduce the thoracic pressure, which in turn moves the diaphragm inferior and increases the abdominal pressure. So when you sniff, the IVC should then collapse. All right, so let's put a little bit of this into practice. And we're going to, of course, go over the lower extremity system later, but just to practice with the waveforms, I wanted to go through a quick evaluation. So let's say that we are evaluating for a thrombus in the superficial femoral vein. So we come just distal to our common femoral vein, and we're going to scan that vein in long optimize our B mode settings, making sure that we are getting rid of all artifact, keeping a nice anechoic vessel, and yet not having it so dark that we're going to miss any thrombus. We're going to scan that area in long, and then we're going to turn on it in transverse, and we're going to start our compressions through the area that we want to evaluate. So in transverse, we're going to compress every 1 to 2 centimeters as we make our way down the vein. Then, if we want to continue to evaluate that vein, we're going to rotate back to long, and we're going to put color on. If we don't have color immediately, we want to optimize our color flow, so turning that color gain up as high as we can, then tapering it off until we feel like all artifactual color is gone. If we feel like our color is not filling the vein, we can augment to try and stimulate that flow and get us nice color flow in the vein. At that point, we can go ahead and add our spectral Doppler, and we want 3 steps in our spectral Doppler analysis. First one is we're going to put our gate in there. We don't have to worry about the Doppler angle this time. And if we document good phasicity for that particular vein, then that would indicate that we have that there is normal patent lumen between the site we're scanning and the vessels proximal to that. Now, if we have heart defects or changes in vascular pressure, we may see additional pulsatility in this region or continual flow. At that point, after you've documented your phasicity and saw what that looks like, then you're going to augment. So you'd pick an area, usually in the calf, if you're doing the superior femoral vein, and you would compress that calf, augmenting the blood flow forward. And if you would want to identify whether you got a rush of flow. If you get a rush of flow, that would indicate that that vein is open from the site of your scan to the site of your augment. It doesn't tell you about everywhere else, but it tells you about the region from augment to scan. If augment does not demonstrate a rush of flow, there may be a thrombus blocking or occluding the area, and so that would indicate the lack of an augment or a rush during augment. Your next step would be Valsalva. So as you're documenting pulsatility, again, you're going to have your patient take a big breath in Valsalva. That Valsalva is going to increase the abdominal pressure, cutting off the forward motion of the venous flow in the lower extremity. And it can also document if there's some reflux there, which would indicate a high pressure venous system or even some faulty valves. If the blood flow fails to cease during this time, it would mean that there's some sort of obstruction between your site of your scanning and where the abdominal pressure are increased. So that would indicate that there could be some clot proximal to where you happen to be scanning. So let's put that to use when we look at our images. So this is a pretty normal superficial femoral vein. So here we have our common femoral vein. Here's our superficial femoral. Here's our profunda. And if we look, we're documenting in B mode, optimizing settings, showing that open vessel. Then they're going to go into transverse. Here we see the superficial femoral artery. Here's the vein. They've compressed it, and it's compressed all the way. They've turned back to long. They probably had to augment here. It looks like they've also moved into power color or power Doppler to pick up those lower flow velocities. But we see nice, good, full lumen set filling here, indicating that there is no distortion from a clot taking up part of that lumen. Then we're going to go ahead and turn on our spectral Doppler. And here we can identify that there's good phasic flow. With respiration, you're seeing those gradual changes with every breath. Now they've added augment. So we see that respiratory flow or respiratory phasicity. Compress the leg, say at the calf, we see a good whoosh of blood flow forward. That would mean that there is no clot between the point of augment and the point of sample. After that, it returns back to normal phasicity. And then here, they are watching that phasic flow again. They have the patient Valsalva. It cuts off blood flow with the exception of just a tiny bit of reversal, maybe a little bit of a valve issue there. And then as soon as they breathe, they're getting that full whoosh forward. So all of those would be significant indicators and good standard practices to evaluating the presence of a thrombus in the venous system. Now, thrombus isn't the only thing that occurs in the venous system, obviously, but it is our most common. The patients that are going to be at highest risk for thrombus are going to be those that have one or more components of Virchow's triad present. So they're in a hypercoagulable state, they're having static blood flow for some reason, or they've had recent trauma, surgery, or injury to a vessel wall. A way that as practitioners, I know you're familiar with, that you can identify how concerned you need to be about thrombus is by using the Wells criteria or the Wells score as indicated over here. That can help you determine whether you need to proceed with the scan or if the patient's symptoms might be something else. Now, if there is a thrombus present, we have to be aware that the appearance of a thrombus is going to change over time. So an early thrombus means that the blood is just starting to coagulate. And so an early thrombus will typically appear relatively hypoechoic with some low-level echoes. As you can see in an example here, it's almost undetectable. And if you were to make your gain too dark or turn it too low, you would hide that. But that's where compressions come in. Now, these are also spongy. So even in transverse doing compressions, you will see them squish, but you'll never get complete coaptation of that vessel if there's a thrombus there. The scary thing about these are the most loosely attached. So these are the ones that you're most likely to throw a clot with. I know as technologists, once we find these, if it looks loosely attached, we know they have a thrombus. Lots of times we'll kind of discontinue our augmenting practices to kind of be careful to not dislodge a thrombus and send out an embolism. As these become more chronic, they're going to become more and more echogenic as they get more developed as a thrombus. They become less compressible, and even as if they become longer chronic, then they can start to break themselves down and become more complex, where you'll have some mixture of echogenicities within it. At that point, if the body is able to resolve this clot, or you have hemolytics or whatever you're using to accomplish that, it may resolve completely. If it doesn't resolve completely and the body is just is stuck with it, then that's when it becomes truly chronic. And when it becomes truly chronic, it's going to be echogenic. It can demonstrate calcification, and it can become very hardened or even occlude that vein so that they'll have to develop collaterals around it. So here's a comparison of 3 different clots. This one is going to be your most acute. You can see how it looks kind of spongy. If my gain was misset, it would be barely recognizable, but it would still deviate the color, which would indicate that there was something there. As it becomes more mature, it's going to have those medium or become more echogenic, be less compressible. And then as it becomes chronic, you might see this complex look. It's going to become more echogenic and become very minimally compressible. And sometimes that vein will just collapse around it. Other venous pathology that we can identify would be venous insufficiency. That's usually caused by damaged or missing valves. Primary would be usually, a congenital defect causing the missing valves or causing just a venous insufficiency problem. Secondary would be caused because of increased pressure system. So that could be something that was like a heart failure, limiting the flow of the blood back up to the heart. It could be something like a tumor compressing the IVC. It could be cirrhosis of the liver. Compressing, the portal system. So secondary insufficiency would also cause your venous insufficiency, which would result in varicose veins. And varicose veins are going to be dilated, tortuous veins that, if you need to follow, can be challenging to follow. And, it can lead to things like caput medusa or other issues such as that. So this is where a lot of venous mapping and that type of thing comes in, but that's probably not something that you're going to want to spend the time doing is in point of care ultrasound, as it can be very time consuming and challenging. So thank you so much for joining us for this second lecture. I hope that you found it a little bit helpful and you're ready to get these techniques put to use in your scanning of your patients. So in summary, specific techniques and utilized in vascular ultrasounds can help you as the bedside provider optimize patient care. If done properly, it can save the patient radiation utilized in other sort of imaging techniques, and it can give you your answers very quickly. It does require a lot of knowledge and skill in scanning, understanding ultrasound along with your anatomy and your physiology in order to optimize the sensitivity of these tests and come up with the accurate diagnosis. And we know that patient habitus has a huge role in ultrasound. We are often limited by our patient's body type and habitus, and so understand that, you know, as a provider, you're still not a miracle worker, so sometimes for certain patients these may not be the best tests, but they may also be the best ones you have in that capacity. Inclusion of B mode or brightness mode along with imaging in B mode when long and transverse, as well as adding evaluation with color flow and spectral analysis, is going to be essential in coming up with the overall most accurate diagnosis you can get. So I hope this was helpful. I hope you have a great day, and we will see you next week.